Hello, everyone. Welcome to today's Lunch and Learn. Give us just a couple minutes to let everybody in from the waiting room, but we're excited to have you. So just give us a few minutes here. Hello, all. Welcome to today's webinar. Give us a few minutes to let everybody in from the waiting room. I can see they're still joining, and then we'll get started. Hello, all. If you're just joining us, we're letting people in from the waiting room. Just give it a minute to get everybody in. Hello, all. Welcome to today's webinar. Give us just a second to let the final group of people in. They're slowly migrating in. Hello, all. Welcome to today's webinar. Give us just a second. We're letting people in. All right, all. It looks like most people are in from the waiting room, so we will go ahead and get started with today's webinar. My name is Liz Skilton. I'm an Associate Director of Research at the Kathleen Babineau Blanco Public Policy Center, and I'm head of the implementation team for Whole Health Louisiana's program. Before we begin, I want to thank everyone for joining us for today's Lunch and Learn on the state and federal holiday of Juneteenth. In line with Governor Jeff Landry's May 2nd proclamation, the Blanco Center acknowledges the significance of this holiday, which commemorates the end of enslavement in the United States and celebrates emancipation through a day dedicated to learning, sharing, and respecting the history, culture, and achievements of African Americans. With this in mind, we're excited to welcome you to our 10th Lunch and Learn for the Whole Health Louisiana series. Whole Health Louisiana is a collaborative effort led by the Louisiana Department of Health as the public sector anchor and funder for the Whole Health Louisiana initiative. The Blanco Center leads the plan's implementation and evaluation. If you're unfamiliar with what Whole Health Louisiana is, Whole Health Louisiana is the state's cross-sector initiative intended to systematically address, mitigate, and prevent childhood adversity within our systems of care and support. WHL has 4 priority areas and goals: collaboration, awareness, workforce, and prevention and healing. With these priorities in mind, WHL's vision is to build a state where children, families, and community members across Louisiana are healthy and thriving, regardless of who they are or where they live. I'm going to turn things over to Quinn Nguyen on our team, who's going to be the moderator for today's session and introduce our speakers. Quinn, please take things away.
Thank you, Liz. Hi, everyone. I'm Quinn. I'm a research associate here at the Blanco Center and the coordinator for the Whole Health Louisiana project. I'll be moderating this webinar and all of our Lunch and Learn webinars to come, along with my colleagues here at the Blanco Center. As part of this initiative, we are holding a variety of different activities meant to raise awareness and deepen conversation about trauma-informed care practices. Our virtual Lunch and Learn series touches on the workforce priority area of the plan and features presentations from industry professionals and subject matter experts. Due to the popularity of this series, we'll be continuing it through the upcoming year, and we'll be focusing on trauma-informed care in specific workplaces, and we'll be kicking it off with Secretary David Matlock next month in July. So our planned webinars are all listed on the Eventbrite page that you'll use to register for today's event if you want to register for our upcoming webinars and want to read more about the topics that we'll be discussing. Okay, before I introduce our speaker for today, I want to mention our ASL interpreter today is Lisa Gill. You should see her pinned to your screen to view the interpretation throughout. And in addition, if you are attending for CEU credits, please remember to fill out the CE credit request form and complete the post survey to receive your credits. Okay, I'm now going to go ahead and introduce our speaker, Dr. Paula Zena, who has worked with children and families with significant medical and psychiatric issues, as well as healthy children and families throughout her career as a pediatric nurse and clinical child psychologist. She provides direct services, clinical supervision, and training for the Pediatric Psychiatry Consultation Liaison Program, a required component of the child psychiatry training, and a core rotation for the child psychology internship program. In her work with the Louisiana Office of Public Health, she is involved in program development and professional training for the statewide home visiting program and provides oversight of the infant mental health consultation for the Nurse Family Partnership. The main focus is on mental health issues related to pregnancy, infancy, and early childhood, including perinatal depression, perinatal loss, mental health screening and consultation, and parent-infant assessment. Dr. Zena's research interests include mental health issues in non-mental health settings, implementation issues in nurse home visiting, chronic illness in childhood, professional development, and sexual self-esteem. So with that grand bio, I'm now going to hand it over to her to begin her presentation. Thank you so much.
Thank you, Quinn, and thanks to everybody who's here today. I know it's a holiday, and so I appreciate your time and being willing to join us. I will say caveat that description of my work is old. So I'm no longer doing a lot of those things, but I am at Tulane in the Department of Psychiatry. I'm still doing teaching and supervision and clinical work, and I'm working right now with a trauma and grief center at Children's Hospital. So I'm continuing to work with children who've experienced significant trauma and so forth. So I want to go ahead and start to share my screen. Let's see if I can get it going from the beginning. Okay, hopefully y'all can see that. Let me know if not. Today I'm going to be talking about relationships as antidotes for trauma and traumatic stress. Now, for some of you, this may be information that you already know. I realize we probably have a range of people with different levels of knowledge about all of this, but I feel like we always need to go back to this and remember this in our work with children and families who've experienced trauma. Here's my disclosures. I am going to be focusing mostly on young children, but much of this is going to apply to children across various ages. I am using some photos of actual children and families. They have given permission to use the content, but I hope you will respect their privacy. And I'm also going to be using some stock images and some YouTube stuff. So a variety of content. Today I'm gonna start really talking about attachment. And again, for many of you, this will be review. For some of you, it might be new information. We're going to think about three different ways that caregiving relationships play as antidotes for trauma. And we'll give examples of that. And then we'll think about a continuum of approaches as well for how relationships can address trauma and adversity. But I first thought I'd, define antidote. I don't want to insult anyone, but, it's something that counteracts the effect of a poison or something bad. We think of anti-snake venom or syrup of ipecac and things like that counteract the poison of a drug or something like that. But more generally, it's something that relieves or prevents or counteracts something that's difficult. Here are some synonyms. And I just thought those were useful to think about in terms of what we're trying to do when we think about relationships in children who've experienced trauma. So I'm going to talk about relationships in three different ways as foundationals, something that we all experience and lay the groundwork for our later experiences, as protective, and also as ways to promote healing from trauma. So we'll go through those today. So again, relationships is foundational. So for those of you who are somewhat familiar with attachment, you know that, and of course the research has been voluminous in the past 50 or so years, but that early caregiving relationships really do put us on a pathway for how our health and well-being and social emotional development develops over the rest of our lives. We know that as brain research has grown, that relationship experiences are both expected in terms of brain development, and they're also essential for early brain development. I'm not going to go into detail about that, but our brains are depending on relationships for growth and development. We know that babies have to have a caregiver. They have to have someone there. They can't survive unless there is a caregiver there. So their experience of being with someone else begins from the very beginning. And we know that the quality of that caretaking experience affects the child's health, development, social, emotional health, and so forth, and can create protective factors or can create short or long-term risk, depending on what the experience is. So I'm going to do a brief review of attachment, and I think it's important to just make sure we're all on the same page about what this means. I'm sure many of you have heard of John Bowlby, a child analyst, who really gave us the words and the ways of thinking about attachment as we're using it today. And his idea about attachment was that attachment is one of the ways that one of the sort of drives that young children have. And for attachment in particular, it's not just warm and fuzzy, wanting to be with a caregiver. It's really about what happens when children are distressed. They get very upset and they have to have someone that they can turn to that can help them through these situations when they're frightened, tired, or ill. So during those periods, if a child, could be anything, they're tired or frightened, ill, traumatized, they're going to look to their caregiver for comfort. They're going to look to their caregiver for support. How do I get through this? For nurturance and for protection. And that's sort of the primary goal or role, if you will, of attachment. And again, these behaviors are hardwired into our brain. There's an expectation that these will occur. And, for those who are deep in the world of attachment, we know that you'll see these kinds of attachment behaviors even in other species as well. In fact, John Bowlby, in part of his developing his theory, used research on animals, but he really came from the clinical world where he noticed in working with young teens, males who basically were delinquents, that a large majority of those had experienced some kind of parental loss when they were younger. A parent died, parent abandoned, something happened where the caregiver wasn't there, and he was seeing the, sort of what he thought were the after effects as they became teenagers. So that's kind of where he came from. So what we know about attachment is that these are the kinds of things that really help develop what we call secure attachment. I'll get to that a little bit more. One is that the caregiver is consistent. The child learns, I can count on you when I need something. And by that predictability, the child learns what to expect and what to count on, how to act, if you will, in certain situations. The caregiver is emotionally available. That means he or she is aware of their own feelings and how that may be affecting the child, and can share his or her emotions with the child, and can see and respond to the baby's feelings and emotions. This is a big deal because I think for a lot of times we think that children don't know or they don't notice and that sort of thing, or we think children don't understand, young children don't understand, but being emotionally available allows us to be more sensitive, again, allowing us to notice when a child has a basic and emotional needs and to respond in a compassionate way. And I will also add that I think young children need a caregiver who really values and finds joy in being with them. That really conveys to the child that he's important, that he's worthy, that he means something to that caregiver. So very briefly, I want to just kind of go through the development of attachment. There is an evolution of it, if you will. Certainly it begins during pre-pregnancy and pregnancy. And we are beginning to develop relationships with our infants even during pregnancy. Some very interesting work done by another Zena, Charlie Zena, a number of years ago, looking at how parents describe their baby's personality prenatally that was not that far off from what the baby's actual behavior was postnatally. We think about the names, we think about the hopes and fears, we think about what that baby is going to be like, not always affected by how much the baby is moving and so forth. In fact, Charlie found that it wasn't the movement in utero that was forming that idea of who the baby was. And some other more interesting work found that parents' prenatal perceptions about the child's personality actually predicted attachment classification at age 1 year. So what we're saying and thinking and feeling about that baby prenatally really has some implications for our relationships down the road. The first couple months, babies are cute. You can see this one here. We're attracted to those cute little babies. We want to cuddle them and so forth. We know that babies already know the caregiver in some ways through smell and through sound, through voices and so forth. But babies at this age aren't specifically tuned into a particular person. And yet they also have some very powerful ways to communicate their needs. For any of you who have done Keys to Caregiving, you know that very young babies had very powerful ways of saying when they want to interact, when they don't want to interact, and expressing their needs. I just want to show you this one little video of a dad interacting with his very young daughter, and I want you to notice the interactions that's happening at this just for a few seconds here.
Oh, 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 oh,
That's a really beautiful demonstration. This actually is a relative of mine who's interacting with his newborn, or she's just a couple months old. And you can see they have this quiet moment of interaction. Some people will call that serve and return. She is totally focused on his face. He is matching her affect and matching her voice with his voice. And at the very end, she starts squirming a little bit and is like, I need a change. And he recognized that, stopped that, and gave her a kiss. Really a lovely, everyday kind of interaction, and really important even as very, very young babies, learning what it's like to be with someone else. From ages 2 to 7 months, we know that babies are very social and interactive. This is a really fun age. They're smiley, they're friendly, they're easy to get along with. They begin to show maybe some differences in how they interact with people, but they don't really have a specific person that they necessarily go to. And they don't really understand that the person isn't there when they don't see them. So they don't have that sense of object permanence that emerges a few months later. Between 7 and 9 months is when more focused or specific attachment really begins to show itself. And one of the ways that we know this is through some of the behaviors that they express with other people. So they may be shy around strangers. In other words, they're looking at these new people and saying like, "Who's that?" And am I safe being around them? And they may turn to the caregiver to get an idea about, is it okay to be with this person? They may really protest when the parent leaves. If you're a parent, you may have experienced this. It can be pretty intense. They begin again to show preference for a certain number of caregivers, and again a focused attachment style with their primary caregiver. Between 12 and 18 months, we know that maybe a little bit before that, children are beginning to walk, they're beginning to move away, they're beginning to really want to explore more independently, which is all developmentally appropriate. But that increase by showing that increasing independence, they walk away, but they still need a sense of safety and security. So parents can be both a safe base that allows the children to go out and explore, but also a safe haven. So when a child feels uncomfortable or not sure about things, they can return to the caregiver, get a hug on the leg, and go out and start exploring again. We want children to explore and to learn about the world. They've got a desire, an underlying motivation to do that, but they also need to feel like it's safe to do that. And so they'll use the parent in this way. I couldn't, unfortunately, pull up the video for this one, but I imagine many of you have seen this. Is an incredible video of this dad with his about 15-month-old little boy, and they're sitting there watching TV, and they have this incredible conversation. And you can even see from this picture that they are sort of intently looking at each other, and they have this lovely back and forth conversation that goes on about the TV, and they're just sitting there talking, and the baby is very animated, and the father again matches the voice and the affect with his baby. And you can see that this dad really enjoys being with him. He's taken the baby seriously. He's interacting with him like he's a real person. And the little boy is just right there with him. It is fabulous. If you haven't seen it, you must go look at it. You can look it up on YouTube where it says, adorable baby talking to his dad or something like that. It's really a fantastic video. And my understanding of this is that this dad was videotaping these things because he wanted to create a number of videos to show his son in later when he got older. And he happened to post it, on YouTube or whatever, and it went viral, and millions of people have seen it now. Anyway, it's wonderful video and a wonderful example of how everyday interactions can be so important for very young children. Still, through the next few months, the parent and the young child are still trying to figure out how to be together. Toilet training comes along, more independence, the nose, all that sort of stuff. And so it's really a challenge to figure out how to let that child be independent, but also be dependent on the parent when is needed. Some of you all may be familiar with Circle of Security. This is a really wonderful resource and conceptualization of what young children need, especially when they're in that early toddler age. And again, you can see the hands functioning as both a secure base and a safe haven. And when the child goes out to explore, you can see here the little bubbles say, I need you to watch over me, pay attention to me, help me when I need it, enjoy with me and delight in me, take pleasure in my exploration. But when I am afraid or when I'm unsure, uncertain or whatever, I need to go back to my safe haven. And that means I need you to protect me, comfort me, still delight in me, and help me with my feelings. Help me to understand what my feelings are about. I think it's really a lovely example of kind of the circle of how children can explore and be safe at the same time. And they've done this lovely, their little mantra of always be, the parents' job is to always be bigger, stronger, wiser, and kind. Whenever possible, follow my child's lead. Whenever necessary, take charge. If you have a chance to get a Circle of Security training, do it. There's parenting education along with this, and these guys are brilliant in the way they conceptualize attachment and early parent-child relationships. I had to show this one because I came across this actually on LinkedIn. Some of you, again, may be familiar with the videos that Dan Wuori, I don't know how to pronounce his last name, puts on LinkedIn. They are fantastic descriptions of normal development. And I wanted to show you this little girl who is trying to jump off this little deck into the water. And I want you to watch how she figures out how to do this.
You can do it. Just do it. Just do it. Bella, I know you can. I know you can.
Okay, I'll just try it.
Okay. Come on, Bella, I know you can. You can do it. Be brave. 1, 2, 3.
Got that! Yes! So I need to take a clap on that outside. Okay, now go.
Ready? Just jump. Just jump. Don't even think about it. Just do it. Get up and go. Ready?
You go last.
You want to go after Jack?
Yeah, because I'm kind of scared.
Okay.
Just jump down.
Woohoo! Now Bella's turn. Ready, set, go.
I'm gonna go in the water. I got this. I'm afraid. I got this. Thunder.
Yep, you got it.
I just can't tell you how much I love that video because this little girl this is a mild stressor. You know, she's trying to do something new that she doesn't know how to do. It's scary for her. She has a lot of words to describe her feelings, which, you know, I'm going to give mom credit for that, and maybe her childcare center where they're now teaching very young children how to use their words. She has several strategies to get her courage up by saying, I got this, and clapping and blowing and sort of building up her courage. And her mom is right there giving her the support and encouragement that she needs, that she was able to accomplish that. I just think it's really fabulous. And this is a great example of self-efficacy, the beginning of self-efficacy and learning how I can do things. Great video. So for secure attachment, you know what, I'm speaking mostly today about secure attachment, but what you can see from what we've talked about is that secure attachment children are, learning that the caregiver is available and dependable. They can turn to that caregiver for comfort, protection, help with feelings. They can feel safe, both emotionally and physically. And they can navigate new situations and new relationships because they've got that person there to help them with that. We know that through many studies that secure attachment is what we want our children to have. It really lends itself to healthy development across a whole range of developmental parameters, including learning and how they do in school, how they get along with their peers, how teachers like them, all of that, grades, and their willingness to try new things, their willingness to persist when things get challenging. You can see, like Bella and even that other little boy, self-worth and confidence can grow because they know that somebody's there and values them and will encourage them to do these things that are new to them. Again, good emotional regulation. Bella was good on that one. They're more safe. They're more aware of when things are dangerous, and obviously they have more positive social relationships. So we're really looking for secure attachment as much as we can. As a baseline, we want this for everybody. We all deserve to have it. However, only about 60% of young children actually develop secure attachment relationships. So I'm not going into detail about insecurity or disorganized attachment, but we know that when children don't have this kind of secure attachment experience, that they do have more risk for social difficulties, learning difficulties, even sometimes more significant psychiatric issues and so forth. But the thing to remember is that attachment is activated in times of distress. So that's when you're going to see what does the child do when they are in trouble and they need help. This is a great example of a little girl upset about something and she's turning to her mom, or I'm saying it's her mom, turning to somebody, I need help, please help me. It's not always easy as a parent to do that, but this is a great example of when there's distress, who do I turn to? I'm going to turn to somebody I think that can help me. Okay, so that is basically foundational. This is where we learn about ourselves and the world and how we can depend on other people. So very much foundational. But relationships can also serve as protection. I'm going to talk about this in a couple different ways. Just keep in mind the literature on this is voluminous, so I'm going to give some examples. But we know that adversity or bad experiences happen. We can't prevent all of those kinds of things. We can't make the world a perfect world where nothing bad ever happens. But we can, figure out how do we get through those difficult times when something comes along. And I'm going to talk very briefly about in some intrinsic adversities that happen that are sort of within the child, and also some extrinsic adversities that may come along through no fault of anyone, but where a relationship may provide some degree of protection. First of all, for prematurity, we know that's birth prior to 37 weeks of gestation, and especially for those who are very preterm before 28 weeks of gestation or very low birth weight, they're at risk for a number of behavioral, motor, sensory, and other kinds of outcomes, including insecure attachment, because parents aren't necessarily expecting to have a premature baby or a baby with a lot of healthcare needs and so forth. We could spend a whole time just talking about all of that. But what the literature shows repeatedly is that even with the kinds of physical challenges that young children with prematurity might have, what tends to be among the best predictor is parent and family factors. So parental well-being, how is the parent able to take care of the baby, respond to the baby, protect the baby, and so forth. SES, of course, confers a certain amount of resources, but those kinds of things can really mitigate the long-term effects over and above the whatever the diagnoses are for very premature babies, except in more extreme cases. Difficult temperament. Temperament is considered to be, biologically based, maybe genetically based, temperament or personality that we all develop. And there's been a voluminous literature again on different types of temperament styles. We know that difficult temperament, which can be either children who are hard to regulate. They may be more irritable. They're not very cooperative. They push their parents away. They don't sleep easily. They're picky on their eating. They're just hard to take care of. We know that children like that can be at risk for later problems with socializing and internalizing, externalizing behaviors, especially if they get pushed away and not responded to. We know that sometimes the infant's temperament clashes with that of the parent. So if the parent's kind of easygoing and then they have this child that's temperamental or that's difficult, that can be a risk for poor outcomes because there's not the goodness of fit. And we know that children with difficult temperament can be more sensitive to stressors that are around them compared to what we would call an easy child and so forth. So we know that these children can be sensitive, that the type of temperament needs parents to adjust or adapt to them and can moderate the effects of difficult temperament. Another form of difficult temperament is the child that's very behaviorally inhibited or shy. And here's just, I hope I can convey this adequately, but here, if a child is very, very shy and afraid to go out and fearful and that sort of thing, we have different ways, of course, as parents that we can respond to that. We can be encouraging them to try things and to be with them and figure out ways to try new things. Or we can be overprotective and say, oh, you're afraid, you don't have to do that and that sort of thing. Here, this study found that starting at age 4-year-old child reticence, so the shyness that they had at age 4 was very similar in the two groups. But the children by age 7, so this is 3 years later, if there was a parent with what they called over-solicitous behavior or overprotective behavior, those children at age 7 had much more significantly more significant social anxiety compared to the children at age 7 who had parents who were able to adapt and work with the child and help the child gain some confidence, gain some skills, gain some sense of that it's okay to go out and try new things. So this is a good example of how parental interaction with child temperament can make a difference for them in the long run. Divorce is another one. We know that's on the list of adverse childhood experiences, and we know that many children experience divorce. The numbers vary, but the most recent one I saw was around 30% of children experience divorce before age 18. We know from years of research that there are a lot of things that children can be at risk for when during divorce. And here are some of the kinds of things that go along with divorce. Where they lose time with the parent's roles changes. There's lots of changes in what the family does, their resources and their economic security and so forth. The child may have to move into a different community. Parental stress may be high, and so forth. We know, however, that there is some research that suggests most children do okay, and may even find some growth in the course of divorce. But what I think we find over and over again is that the things that protect the child during divorce from all the kinds of issues that can emerge from divorce is that they're able to maintain relationships, a good relationship with both parents. The parental stress and parental adjustment is on the good side. In other words, if the parent is highly stressed, it's hard for them to pay attention to what the child needs or to respond to them in what they need. So parental adjustment matters. Again, parental mental health and having social support around. Co-parenting is helpful. And of course, practical support. So the ability to get the kinds of resources that are needed. But you can see here that what seems to be the most important thing is their relationships with their parents, and how the parents are able to respond and take care of them. Natural disasters, I couldn't help but include some of this given we're going into hurricane season. But we know that in general, again, same kind of thing. A natural disaster comes along. How is the parent or the caregiver responding to the child during that disruption? Again, if the children have strong social support, have practical support, have other people around them that can help them, then they're going to do better. My example of this is always around Hurricane Katrina, where if a child is with their family, they go to their home, the home is destroyed, and the parents are like, oh my God, we're never going to get over this. We've lost everything. And they're totally preoccupied with that, which many people were, rightly so also. That kind of leaves the child hanging like, am I going to be okay? Am I going to get through this? Is my parent going to be okay? What's happening to all my stuff? As opposed to the parent who might say, this is terrible. We've lost everything, but we're going to get through this together. You're going to be okay. I'm going to make sure you're okay. Very different message with the similar kinds of experiences. Again, across a whole variety of studies, Ann Maston is someone who's done a ton of work on resilience. Again, children need that supportive, effective, and safe caregiving, hopefully from the person that's considered to be their attachment figure. There are people who are helping to solve problems and figure out what we're going to do, help them to regulate their behavior, and still allow opportunities for self-efficacy, and really convey a sense of meaning despite the disasters, a sense of hope and a sense of meaning of how we're going to get through it. Here's another one on war. Again, kind of relevant for today, although this is an older study that was done with 132 preschool children. This is in Israel. And what they found, I can't remember what the year of the study was, I'm sorry, but Israel was being attacked a number of years ago. And they found that of these 132 preschool children, 47% had been diagnosed with PTSD. 47% of very young children. Now, some of this was predicted by the mother's exposure, not the child. So that's important to keep in mind, that the parent's well-being can be the near experience, if you will, for young children in terms of their own psychopathology. So they did a task where they evoked a memory of the bombs and the rockets that came through this area of Israel where the attack took place. And what they found was that for these young children, if the young children were able to turn to their caregiver for help, for security, for protection during this memory task, they were much less likely to have PTSD also. In other words, if they were showing what we would consider to be secure-based behavior with their caregiver, even in the midst of being exposed to a memory that might have been very, very scary, they had less PTSD. So I think that's again another example of, even in very scary times, the parent can be protective or perhaps can be a risk factor for the child's own symptoms. I want to mention real briefly about positive childhood experiences or benevolent childhood experiences. I'm sure you've heard of these to some extent, and there's been lots of discussion out in the world about this because we say, well, what can we do? There's got to be a way to counter some of the effects of bad experiences that young children have. And various groups have defined what positive childhood experiences would be. Some of it has to do with access to resources, like housing stability and having a two-parent family and socioeconomic status, parental education. Those are things that kind of always are important in the long run. But also parental warmth and emotional support, instrumental support, helping children get through the day, practical support, and so forth. The Slopin article was actually looking at children experiencing cardiac risk. Again, nurturing and supportive relationships, protective, equitable environments. You can see the list. I'm not going to go down and read the whole thing. The Beeses, Alicia Lieberman and her colleagues have sort of been the one to really talk about Beeses, benevolent childhood experiences, or the angel in the nursery kind of thing, where the child has had some positive experiences with a caregiver despite being exposed to traumatic experiences. And so there's a lot of hope around that for how these will work for us. But there is a literature. This Kunha is a systematic review, very recently came out. And you can see in general, the higher positive childhood experiences are associated with better mental health outcomes in adulthoods. And the lack of those may be detrimental. However, other research shows that that positive childhood experiences may work for some things, like physical health and exposure to other stressful life events, but not necessarily for other kinds of adverse childhood experiences. So it may be that ACEs and PIECEs or positive childhood experience are independent sets of experiences that may coexist, but the positives don't necessarily moderate the consequence. So I'm just throwing this out here because I'm talking about relationships as kind of the panacea for everything, but we have to recognize that we need more research on this, and it's still something to keep an eye on and not to dismiss, but we just need to know more about how the positives interact with the adverse experiences to have an effect on outcomes. All right, so finally, I want to talk about relationships as healing. And again, we could spend lots of time thinking about this, but I'm trying to differentiate, sort of what's baseline, what's protective, and what can be healing, because we know that sometimes children have significant stresses, toxic stress being the term that a lot of people use. And we know that the research shows that toxic stress really disrupts brain architecture. It really is what leads to later stress-related diseases and so forth. And it really is considered to be that kind of stress where the child doesn't have any protective figure, doesn't have a way to get out of whatever the problem is, and is kind of left on their own. So abuse, neglect, chronic institutional care, those are the kinds of things that often lead, that would fall under the realm of toxic stress. A little bit of stress, like Bella's stress, trying to jump in the water, that's a good thing because she's learning from that. But this toxic stress is what really can have long-term adverse experiences. This is just a a quick slide, not a quick slide, but I'm leaning on my husband's work from Romania. And they were looking at children longitudinally, children who'd been in orphanages or institutions in Romania. And some of those children were removed and put into foster care, got into good family care. And others remained, in the orphanages and so forth. It's more complicated than that, but that's in a nutshell. And you can see here that for children who have extreme neglect, where their emotional and physical needs are not being taken care of, this is at age 8. Their brain power. This is a little video of or a little picture of actual brain power. So you're looking down, the little triangle at the top is the nose. So you're looking down from the head onto the physical, the activity in the brain. The red is, or the orange, it indicates more activity. So, just to look at this, extreme neglect is very detrimental to brain development. This is actually where some of the research has come about the effect of toxic stress on brain development. And certainly, even though the children started off in the orphanage, being then raised in a family conferred some positive development for them. I'm gonna, yeah, scoot that. Okay. Another example from the Romania study, where they're looking at the effects of quality of caregiving when the baby is at 30 months to the psychiatric symptoms at 54 months, so a little over 3 years. Is that right? Yeah, 3 years. 5 years, I'm sorry. So at 30 months was when before 30 months was when they made the decision whether the child would stay in the orphanage or not. They were randomly assigned to either stay in the orphanage or go into a foster home. And they've been following these children for many, many years. So here we see that although the quality of caregiving at 30 months led to, better quality of caregiving led to fewer psychiatric symptoms and impairment at 54 months, the question was, how does that happen? What's going on? And when they measured security of attachment and looked at that, what they found was that the quality of caregiving was actually mediated by the security of attachment at 42 months. In other words, this positive connection between quality of caregiving and at 30 months and 54 months symptoms was affected by the security of attachment. And those children who had secure attachments at 42 months were much, much less likely to have psychiatric impairment at 54 months. I hope you're following me on this one. But again, this is basically a treatment, if you will, for children who've had significant adversity. It's essentially the relationship was treatment for these children who had come from very, very dire circumstances where they had experienced severe neglect and many times many other adversities as well. I want to show you a video a little bit closer to home. And again, some of you may have seen this one. This is from from Child Protection. Again, I'm leaning on my husband's work on this. And if you've seen this video, I hope you enjoy it because I think it's just such a powerful statement. What you're going to see here is the interactions of a young child with his caregiver they're in a program for children who've been exposed to abuse and neglect. They're in child protective custody, in other words. And this is part of a standard assessment procedure where they have the parent and the child play as they normally would. The little boy is about 15 months old, and you'll see here he's playing with his mother.
Pancake, pancake, bacon, pancake, pancake, bacon, pancake, 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 bacon, roll up, baby, roll up, throw 'em in the van. Pancake, pancake, bacon, pancake. Oh, pancake, pancake, pancake. Pancake, pancake, pancake. Look.
Bubbles is something that they use because oftentimes playing with bubbles as something gets children very excited and they're fascinated by it. And they find enjoyment in it.
Yeah. Look. Look. Now.
At this point, the mother has left the room. This is part of their standard procedure, and they're observing what the child does when the parent leaves. Again, remember he's 15 months old. He's going to the door to see where she is, looking for her. Kind of a search. Cries a little bit, rocking. With this real despairing cry there, really kind of a hopeless cry, if you will. Mom is knocking on the door. It's hard to hear all this. She's letting him know she's coming in. He sees her, looks at her. Then he kind of starts to crawl out of the door. Mom picks him up. He cries. She tries to comfort him. Tries to distract him. Puts him down, but he's still not comforted. And just again, to remind you all, these families have given permission to show these videos for educational purposes. Trying to distract him, trying to get him to, interact positive, and he's just irritable, unhappy, fussy. And it's hard for mom because she's trying to do something and he's not being very receptive to her efforts. So to make a long story short, this child was at the time we saw that video, he was in a child care, he was in a foster home. Because of issues in the foster home, he was moved to another foster home, and he was seen in the clinic about 3 months later with a second foster parent. And I want you to see Harold now.
Fine. Check you later. Say check you later, dude. Oh. I see you later. Bye. All right. Say how you doing?
Having conversations here, kind of like the other little boy we talked about.
All right. Check you later, dude. Say check you later, dude. Oh. Say how you doing? Say hello. My name is Harold. Who do you want to speak to?
Nice back and forth conversations. Bubbles, another example with Bubbles. He's walking. He's having some fun. He's looking for those bubbles. Smiling. Along with a foster mom who's also smiling with him. This is another part of the evaluation where she has left the room, and he's wondering if she's coming back in. Comes to her and wants to show her something. Happy to see her. And then she nicely responds to him, doesn't overwhelm him, and he's happy to be back in his arm. If we watched it a little bit longer, you would see that he actually goes back to play, which is what we want to see. We're looking at that reunion. How do they negotiate that stress of being away from the caregiver? Ideally, the caregiver is able to comfort the child, and the child can go back to the exploration that we want them to do. I love Harold. Harold is a wonderful example of how the caregiving environment really matters. I'm not advocating for taking children out of homes and all that kind of stuff, but I do think it does raise the question of what is it that children need? And certainly for him, affectively, behaviorally, developmentally, he really sprung to life and was essentially a new man three months later. Bio mom had some significant psychiatric and substance abuse and depression concerns that was made it very, very hard, was barriers for her to be able to take care of him adequately. But you can see what a difference a caregiving environment can make. So I'm going to stop almost at the end here. So again, I want to just emphasize again how early caregiving relationship experience really provide a foundation for children to learn how to be with other people, especially in times of need, how they think about themselves, how they approach challenges. We know that children with secure attachment have many, many, many more positive outcomes, the things that we want for our children and for us. That safe, dependable, sensitive, nurturing, caregiving relationship we want for every child. Every child deserves it. When risks emerge, that relationship can provide protection. It may increase risk, but a secure relationship can confer protection. And when there's been really severe disruptions in caregiving, that safe, secure, nurturing relationship can actually be a way of healing for them to merge out of that very toxic environment. I think it's important to remember, in my opinion, when we look at all the adversities that are out there, they're almost always, when there's a bad outcome, they're often associated with disruption in the caregiving relationship. This is not to blame parents or whatever, but that if parents are preoccupied and consumed with whatever the stressor is that they're dealing with, it then can sometimes mean that the child is not getting their needs met, their experiences are not being taken into consideration. So again, when we think about relationship supports, we might want to think about it along a continuum. And this is going to look familiar to many of you, but sort of everyone needs that good, secure attachment. We need to help parents understand and educate everyone about the importance of secure attachment, of sensitive caregiving, of all the kinds of things that go along with encouraging a secure attachment. We can really look at targeted situations to really help beef up the protective function. And we can do that with risk groups like in home visiting, early intervention, parents who have mental health conditions. All of these things don't necessarily mean there's going to be a bad outcome, but it's a good opportunity to help build those protective relationships at that time. And then for those children who've experienced really severe stresses or toxic stress, relationship must be part of this. We must have dyadic approaches and oftentimes multi-pronged approaches to help children overcome those. But the caregiving environment may be the most important place to go. So again, if there's only one thing you want to do to prevent or mitigate the effects of trauma, make sure that those caregiving relationships are safe, protective, dependable, nurturing, so forth. So I'm going to stop with that. See if I know we're probably down to the last few seconds here, but I'm going to stop the share and see if anybody has.
Thank you, Paula, for that amazing presentation. So I know we're almost at time, everyone. But we're gonna stay on for about 5 minutes to answer any questions or comments that y'all might have. And I do want to remind everyone about the post survey that will be sent out after this webinar. So if you are getting CE credits, please be sure to fill out that survey. Even if you aren't getting CE credits, we really, really appreciate it if you do fill out that survey as well. It helps us improve our webinars. Okay, thank you. So I'm gonna now start fielding any questions. If you have any questions or comments you would like to say to Paula, please do put it in the Q&A box down at the bottom. I do have a question for you, Paula, if you could answer it. So, at the Blanco Center, we are focused on policy. And so from a policy standpoint, I'm wondering, if you read any studies, that incorporates, all the things that you talked about, so we can, prevent insecure attachment styles. So basically my question is from a policy standpoint, how do you think we can help families and caregivers build secure attachments or relationships with their children so we can prevent trauma and PTSD symptoms and etc.?
That's a good question, the $500 million question, really. I mean, I think we have to do what we can do. First of all, we need to recognize how important those early experiences are and do whatever we can do from a policy perspective to ensure that the children's caregivers are able to provide the care they need for those young children. That may mean having good childcare. It might mean having adequate mental health supports, those kinds of things that are out there, and not blow off the young children. I think a lot of times our policymakers don't even think that young children understand or are affected by what's going on around them. I hope we're doing better with that. But certainly from a policy point of view, if we're thinking about how to prevent or protect from ACEs, we need to be thinking about how are we making sure that parents are able to take care of their babies safely, securely, able to nurture them, and so forth. And different families need different resources for that. But we certainly need to be not taking away resources. We need to be making sure that we have adequate resources for families. Kind of a generic answer, I know, but it's still important.
Yes, 100%. Someone asked, you might not be able to speak for this to this for various reasons, but curious how Harold is doing today, if you happen to
It's
know.
That's such a great question. And Harold is in our hearts. He was removed from his mother and he was adopted, not by the mother that we saw, but by someone else. And they moved out of state and they have not been able to keep up with him. We would like to know. The team that was working with Harold and other children like him a number of years ago did a look back on the children that went through the program. It was infant team, and they found that the things that were most predictive of children not doing well were things like severe maternal depression and substance abuse. So aiming at those kinds of things that really interfere with parents' ability to take care of their children is really important. I think a lot of people, I've heard many people say, I grew up poor. Resources are important. I don't want to minimize the importance of resources, but it's still possible for people who don't have a lot of financial resources to still be loving and nurturing and protective of their young child. So we need to think about how are we doing that? How are we talking about it for these young children?
Thank you for your answer. We have another question. And this one asks, with the current focus by the Louisiana state government to promote keeping children with parents versus options like childcare, how do you see the future of children like Harold unfolding? Will there be a push to give parent resources to mitigate sources of trauma at home? Is that even reasonable to expect, or will more children be exposed to trauma due to this state focus?
Great question, and I'm glad Judge Matlock's going to he can answer some of this next time. I mean, I'm concerned about the fact that sometimes the decisions, I'm not myself immersed in the child protection system, but from what I understand and from what I hear and what I see, that sometimes the zeal to keep children with a caregiver who is inadequately functioning and maybe not with adequate resources takes precedence because they're the family member, takes precedence over what's the best experience for the child. And I think we have a real ethical dilemma about who are we taking care of? Are we taking care of the parent? Or are we taking care of the child? And I think that's something we have to really grapple with. It's not that these are easy decisions. I'm not advocating for children being yanked out of their households and sent someplace else and all of that. But I think how we assess these families, how we support these families, how we make sure that they've got the resources they need is really important. And we really do need to think about what that child's experience is with the caregiver, as Harold so beautifully demonstrates. You know, if you're living with a parent who's depressed or preoccupied or has their own issues going on and they're not able to respond to and interact with that child in a way that's growth producing for the child, at what point do we say enough that the child's needs are more important than the parents? And I'm not saying these are easy answers, but we need to grapple with that more. And I'm worried about that we only take one side of this as an organ, you know, in our systems, and that we are now talking about removing certain types of resources and so forth for families.
That's a great answer. Thank you. So it's 5 minutes, so I'm gonna go ahead and wrap it up. Thank you again to our speakers and to Lisa Gill for interpreting. Thank you everyone for coming, and we will see you for next month's webinar with the CFS Secretary David Matlock. If you have any questions, please feel free to email us. Thank you, everyone.
Thank you.